We are now live.
Hey everyone, welcome back to another session. Today we have Dr. Emily. She's a general dentist and she'll be sharing some tips and advice for us and hopefully some cases too. So whenever you're ready, you can begin.
Okay, great. Hi everyone. It's great to virtually meet you. I'm super happy to be here and I'm super happy to share kind of my journey so far into dentistry. First of all, I want to say that you should all feel really great about choosing a career that is super fulfilling, super rewarding, where you can feel really respected in your community and have the ability to impact people's lives. I feel really fortunate, honestly, that I get to do what I do every single day. So you guys have so much to look forward to. I remember having so many questions when I was in your shoes, and also that I sometimes didn't even know what questions I needed to ask. So this is such a great thing that you guys are participating in, and I know with COVID you didn't necessarily have the opportunity to go into so many offices physically. So it's great that you're here. Today we will kind of go through my education and how I got to where I am now. Where I currently work and what that's like, and I'll go through a couple of cases for you guys at the end and have some time for questions. So I did my undergrad at Penn and I majored in anthropology. Technically, I had like a subspecialty in biological anthropology. And I picked anthro because I felt like at my core, I most enjoy learning in humanities-based fields. I really didn't want to major in one of the huge sciences. That's just not my thing. And I wanted to take advantage of everything else that my university had to offer, which were some really cool other departments. And I would be lying if I said that there wasn't also a little bit of strategy involved here in terms of maintaining a good GPA. You know, I knew I was good at these courses. I knew I'm really great at writing a paper and having, you know, the types of discussions that we had in anthro. And some of the big core sciences were really tough for me. I was not great at Gen Chem or physics. And so I felt like for my own sanity and enjoyment and also, you know, likelihood of getting into dental school, I needed to balance that out with some other types of courses. And I also think that it actually ended up making me a really marketable dental applicant, because in all my interviews, all my interviewers always wanted to talk about it. They were really interested to have met someone who was not a bio major. So I would definitely encourage any of you guys who are younger and still contemplating what you want to major in to do something that you're passionate about. Do something that, you know, can make you happy, as long as you can obviously take your basic sciences that are needed in addition. So I did my dental school at Columbia after that, and I graduated 4 years ago in 2017. And let's go to the next slide actually. What's dental school like? Let's talk about that. Dental school, when I was sitting down to write this, I was kind of conflicted because I have some really great memories from dental school and I also have some really terrible ones. Dental school is all of these things that I've written. It's really fun. It's so hard. It's really rewarding. It's frustrating. It's busy. It's time consuming. It's amazing. And sometimes you feel like you are just crushing under the weight of a huge boulder. So it really is all of these things kind of rolled into one. You know, you are finally kind of on a concrete path where you're actually reaching your goal of becoming a dentist. So that feels really good. And you're surrounded by all these other people who are super unique and interesting and intelligent and diverse and also a lot like you. You do kind of like become a family and you bond in a way that nobody else in your world really understands what you're going through. So I would say, you know, in dental school, you have to take care of yourself because there's just an infinite amount of things to learn and do and accomplish and take care of. And, you're surrounded by all these other hyper motivated people who may seem like they can handle it all, and you want to keep up. So, keep your life as balanced as you can, eat well, exercise, take breaks, see your family, and just kind of embrace all the highs and the lows. I would say, I can almost guarantee you that by the time you graduate, you'll probably have a laundry list of negative things to say about your school. And I know this because when I got to residency, I thought that, I had all these negative things to say and nobody else could possibly top them. But then I got to residency, and everybody else who went to all these other schools that I thought sounded amazing and, better and perfect, and for all these other reasons, everybody always kind of has their own gripes with their school. And you have to kind of keep things in perspective when you're there, because you have to recognize that these institutions are really old and sometimes a little bit outdated in their methods. But the truth is that no matter where you go, you will get a very fine, and I mean fine in like an excellent kind of way, not like an okay fine, but like a finer things in life kind of fine. You'll get a very fine education at all of them. And really the bulk of the work, the bulk of the learning comes after you leave anyway, in terms of real world dentistry. So, when I was applying to schools and I was interviewing, and I remember thinking like everything was so important. Every single factor was the most important. How many clinical hours do you get? How many crowns will I prep before I graduate? Do I start seeing patients in first year or second year spring or third year fall? And everything kind of seemed really high stakes, but realistically, they are all great schools, and you will graduate from all of them with some sort of experience that gives you a leg up when you leave, no matter where you went. So after I graduated, I did a residency, and I don't know where in the country all of you guys are from right now, but New York State is where I practice. New York State is, they have a mandatory general practice residency. So I know that many, many other states do not have that. And I would say do it anyway. This is truly where I learned how to be a confident dentist. It's so important. It's so good for you, for your career, for your development. It's so educational. It's so valuable. As you can see, I chose to stay at my program for another 2 years after my 1-year GPR. So obviously I have really great things to say about it. And for all of the not amazing things I have to say about dental school, I have truly only the best to say about my residency program. I just loved it. I cried tears of sadness when I graduated at the end of my 3rd year, because I just loved it there so much. So in terms of the GPR itself, which was the first year, I got tons of clinical experience, which personally I did feel that I needed, because if any of you have started researching schools already, you may have heard some, stereotypes about different places. And, the typical one for Columbia is that they're not really known for graduating super strong clinicians, especially general dentists. They focus a lot on your medical education, and they kind of bank on the fact that a lot of people go on to specialize anyway. And if you don't specialize, then most of you are staying in New York and you're going to do a residency anyway. So I had a really strong, science and medicine background, and I was totally equipped to handle, lab values and what's going on with this person who has diabetes or heart disease or whatever it is, but probably fewer actual clinical hours, drilling than some of my peers. So GPR was kind of like a fast track to getting good at real dentistry, learning techniques that are better than what some of the fossils in dental school teach you, learning how to manage your time, how to get good at diagnosing and treatment planning, not just using the drill. And one of the biggest strengths of my program, I always felt, was the attendings. My program director was excellent, and our attendings were all volunteers. So they were all relatively local dentists who have their own practices, who would volunteer their time to come in and teach with us, once a week, sometimes every other week. And they were just phenomenal. It's really nice to come into residency, and on day one, you're being introduced as doctor, of course, to the patients. And when you're introduced to the attendings, they say, like, do not call me Dr. This, just call me Mark. And they treat you like a colleague from the outset. So that was just a really great environment to be in. I felt really supported. And I got to do some really, really awesome cases. Also, huge, I guess, positive, although at the time kind of felt negative, was that we had a tremendous amount of emergency on-call experience where we would, have a shift overnight to manage the emergency room and all dental emergencies that came in, such as dental infections and swellings, abscesses, trauma, people who, were in fights, were in car accidents, children. The nice thing about my program was that it was at 2 hospitals that are kind of like joint sister hospitals on Long Island. So North Shore is a level 1 trauma center for adults, and LIJ is a level 1 trauma center for pediatrics. So we kind of got the whole gamut of what goes wrong in the middle of the night. And even though it feels terrible to have to get out of bed at 3 a.m, it made me comfortable, honestly, handling anything. And so I'm pretty grateful for that experience. So, specialty. I am obviously a general dentist, as I said, but I did stay, I'm sort of like a pseudo specialist. It's not like a board specialty, but I stayed to do a 2-year fellowship in implants and advanced prosthodontics. So I'm not a prosthodontist, I'm not a neurosurgeon, I'm not a periodontist, but I do all that stuff. And that's what I love. I love being able to handle complex cases. I love doing surgery. I love doing perio. I love doing restorative and cosmetic work. And so I just really didn't want to narrow myself down to just one. Who knows, as I go through my career, if I'll end up kind of narrowing my focus a little bit. But as of right now, I love doing kind of everything. So, as I was going through my first year of residency, I started asking myself, what are my long-term goals? What am I trying to achieve? And for me, my intention in my career is not just to be a successful dentist. It's to do truly elite dentistry, life-changing, smile-enhancing, thank you so much, doctor, for making my dreams come true kind of dentistry. So for me, that meant getting some more extensive training in more complex work. And I wanted a leg up in the job market once I got out there. And so my fellowship was primarily for implants, but also because I ended up being at the same location for 3 years, I was able to do a ton of tooth-borne prosthodontic work too, veneers, crowns, full mouth rehab. And in my fellowship, I was able to take patients from the point of, the teeth that need to be extracted, extracting them, putting in whatever bone graft and tissue regeneration they need, to placing the implants surgically, doing sinus lifts if they need them, and then ultimately inserting the final prosthesis. So this was, I just don't have enough wonderful things to say about it. I feel really confident doing this kind of work in private practice, even though I'm young, which is pretty unusual, I think, for a general dentist. And the beautiful thing is you can learn how to place implants anytime. And a lot of my general dentist peers kind of had the attitude like, well, I'm done, I'm done with school. I'm done with the learning. I just want to get out there and start earning. I want to make money. I want to start paying my loans. I want to feel like a grown up. And that's totally understandable. And, you can go to a weekend course with any of the implant companies and learn how to place an implant, or you can go spend a week in Tijuana and place like 50 implants, and then come back, and if you feel comfortable, you can do that. But you don't ever get the follow-up. You never get to see a year from now, what does that look like? You never get to see, even like a few months later, that implant that you placed that you thought was a home run, did it actually integrate? Did it not? And of course, I got to see follow-up from fellows who were in the years above me, who, patients who had their final prosthesis inserted 10 years ago, and now there's a complication, and now I had to manage it, which sucks, but also is so important, because you can't just bop around from practice to practice and city to city your whole life avoiding your complications and your failures, because things will fail. This is biology. This is dentistry. Stuff happens, and you have to be able to handle, the consequences of something that you started. And so when you are able to handle that well, then your patients won't, hate you. They'll thank you, and they'll still come to you because they trust you, because you've got it in hand. And so that's all stuff that I learned in my residency and my fellowship. So I would say, I've always been the type of person who really places a high price on education. So to me, taking a little bit of a financial hit to delay entering private practice full time for 2 years was totally fine, and something that I felt like would pay off anyway. A brief detour here in my path. I'll just talk about some mission trips that I've done, in case you guys are interested. I would say be really, really careful if you go on a mission trip when you are not yet a dental student, because it is illegal for you to take out teeth and do essentially anything like irreversible to a patient. So a lot of trips, the people will be lax, and you'll be in the middle of wherever in the world, and they'll nudge you, and they'll say like, hey, take this tooth out, it's fine. And if you choose to do that, do not ever tell anybody in an interview for dental school that was a rewarding experience for you, because it was illegal. Anyway, I've done 2 different types. I've done in dental school, I went to a clinic called Somos Amigos, which is in the Dominican Republic. And one of the things I loved about this trip is that it is a fully operating medical and dental clinic, and it runs 4 times a year. So the people in the area come for essentially comprehensive care, because they have doctors and dentists and nurses who are there for them year after year. People come literally and get a cleaning every 6 months, because the clinic is open, which is more than a lot of people in America do. So the nice thing about that is you're not just showing up, taking out a whole bunch of teeth, and then disappearing. There's continuity there. You're actually helping to uplift this community, because they can have recurring visits, and they can actually stay healthy medically and dentally. So this was a really great experience. It's up like in the mountains in the DR. We did like a homestay with some local people, and you just work your ass off. You're up super early, and you're there late, and there's good food and good people, and it was definitely something I would recommend. You don't have to. There was a group of us from Columbia who did it, and usually Columbia sends a group every year, but you don't have to be a Columbia student to go. there would be people who come, private practice people, somebody comes with their dad, or somebody comes with their boss, or anything like that. So look it up if you are interested. And then something else that I've done is called RAM, which is Remote Area Medical. And I started doing this in residency. I go once a year now. RAM has programs all over the place, but they have a ton in Tennessee. So I usually go to the one in Knoxville, which is Super Bowl weekend every year. And they set up basically like a huge clinic in like a community center. So you can see in that picture on the bottom, there's just tables and tables and tables with these chairs and mobile dental units. And there's dentists and dental students and hygienists and hygiene students. And they also have like an optometry setup where people are getting glasses, and they have general physicians too. So you can go and do general dentistry. You can go, and usually when I go with one of my oral surgery attendings from school. So we all kind of go as like oral surgeons, and we just take out a lot of teeth. So it's nice to have kind of both experiences in terms of mission trips. Okay, so let's talk about my current practice. I work at an office that's called Dr. Jackie Smiles, which is in Manhattan on 40th Street between Madison and Park Avenue. And I've been in this office for a year now. And I will tell you a secret, which is that I have worked in 7 different offices since I started job hunting, which was not that long ago. And some I was in for as little as a day, and some I was at for 6 months. This current office is going very well, and I'm very happy there. So this is my dental home for the time being. But why so many different places? The short answer is there's a lot of crap out there. I kind of always imagined that I was choosing a career that I would graduate and get out there and just start being amazing at my job and making a lot of money and feeling really good about what I do and not coming home super stressed. And the reality is that when you are a young dentist and you don't have like a parent who you're coming into their office, you're looking for something, you're looking for anything good, anything that's going to feel sort of like a good fit for you. And there's a lot of crap out there. I'm also speaking from New York City and the immediate suburbs. So I believe that the job market in other places is a lot kinder and just generally a lot just better, more friendly for you as a young dentist. But alas, I am a New Yorker. So, there are practice owners who are scumbags. There are offices that are too disorganized to collect money from patients or to bill properly to insurance companies. And there are some places that are perfectly acceptable, just not for you, just not a good fit for you. And this takes some time to figure out. And it has taken me time going through all this to figure out what's truly important to me as an associate and as a dentist who is working under my own license now. So in terms of, deciding factors, there's, of course, the obvious salary, hours, patient flow, expectations regarding what procedures are done in the office. And then there's the not so obvious. And there are so many, and some of them weigh heavier on you than others, and some are negotiable and some are non-negotiable. There's what type of insurance does the office participate with? Because whether they admit it or not, that does influence how many patients you'll need to see in a day and how long you get to do certain procedures, and if you're double booked, and what type of procedures you'll end up doing. So all of this matters. And if there are some people who are very well equipped to work at a very fast pace. I just am not one of them. I feel that it's more in line with my personality and my style and my values to give what I feel is an appropriate amount of time to spend with a patient. And so, but there are other people who are like, go, 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 and they're happy to just bang it out, and they feel that they've done, a job well done. So you have to know who you are as a dentist, and that also takes some time to figure out. It took me trying it out in some offices to really understand what it is that I need. Some other factors in picking an office is the vibe, the attitude. Do you go in and people are happy to be there? Do you go in and people are contemplating quitting every day? How involved is the owner? Is there flexibility with labs that you use? Is there technology available that you can use? Is there flexibility with ordering supplies that you like to use? If there are other doctors in the practice, how long have they been there? Is it a kind of like a revolving door of dentists through the office where when you meet a patient, they say like, how come I've met a new dentist every time I've been here? And of course, is there a flow of new patients? Is the office doing any marketing? So all of these are super important. My number one is mutual respect with the owning dentist. If I feel that I'm being treated like a nothing, then I'm out, and that's okay with me. So, the reality is that there's no perfect practice, and I think probably nothing will feel perfect until it's yours if you want to be a practice owner. And even then, it'll probably be really hard to make it, the perfect baby that you want it to be. So my advice would be, don't be afraid to experiment and find what works for you personally, professionally, financially, all of it. So a typical day in my office is I work 4 days a week. Wednesdays are our late start, late nights. And this was a process to build up to what is currently the 4 days a week. Hence why I was also experimenting at some other offices on my other days of the week, because when I started this office a year ago, I was at 2 days, and then we grew into 3, and then we grew into 4. There are some offices who may be ready to hire you full time right off the bat. Usually these are corporate offices or places who happen to have an associate who's leaving. But sometimes an office isn't ready they don't have necessarily the patient flow to take you on full time right away, but there's the opportunity to grow it. And that's hard to assess. Is it actually going to grow? Is it actually not going to grow? It feels like a little bit of a gamble. Fortunately for me, this does seem to be paying off. And so I do feel fortunate in that way. But I've crawled through the mud a little bit to get here too. An interesting thing about my current office is that the practice owner is actually an orthodontist. So she has developed like a GP practice within her practice. And so she and I are the only 2 doctors, and we have totally different schedules. And so I have a lot of freedom since I'm the only GP. And so that's one of the things I love. I have a lot of autonomy to structure my schedule the way I'd like in terms of the procedures that I do, what I refer out, and how long I need. You can see at the bottom of this list here, what's missing: root canals. Not for me. There's a large contingency of general dentists who love doing endo. They've gotten really good at it. They feel they can do it efficiently, and they enjoy it. I have tried to like it, and I just don't. I just hate it. It makes me really anxious. It makes me really stressed. I don't feel that I'm as good at it as other people, especially the endodontists, and I don't feel that it's a worthy use of my time in terms of payoff, because I'm so slow at root canals. So I refer them out. And fortunately, there are other procedures that I do like to do that we keep in-house that also pay off in their own way. I put a little star next to fillings, crowns, inlays, onlays, because that's sort of the bread and butter of my everyday. There are certainly, the extractions, the implants, the veneers, the dentures, but they're not nearly as often as those 4 procedures I mentioned earlier. And I take tons of photos. I have my camera. This is my setup. I have a macro lens and I have a ring light right now. One day I'll graduate and I'll get the twin flash that has the 2 on the side. But for now I'm working with a ring flash and it works great. Some other things I love about my office is the staff is amazing. The patients are really wonderful. There's a lot of different needs that they have. I really like being in Midtown Manhattan. The patients have a pretty high dental IQ, so they're invested in their oral health. And just as a little aside, I am a lefty, and if any of you guys are lefties out there, it's pretty hard to find a setup that is actually comfortable for you, because most dentists just did not think about that when they designed their operatory. Even if they happen to have a new type of chair that is convertible for a left-handed dentist, usually the architecture of the room isn't really conducive for it. So fortunately, also at this office, I have a pretty good lefty setup. Okay, let's move on. We'll do a couple cases. So this case that I'll show you here is a full mouth case. Okay. So this patient came to see me. Her chief complaint was that she grinds her teeth and she knows it. She has some pretty bad jaw pain with headaches, and she wanted to beautify her smile. Her daughter was getting married in a year, and she knew that it was time. So when you look at this patient's intraoral photos, these are some of the things that I see, just right off the bat. Number 1 is that she has generalized wear of her lower anterior incisal edges and her uppers, mostly just on number 8 and 9. This is very, very typical of a grinder. And because she has lost some of that tooth structure from the incisal edge, she has also lost what's called VDO, or vertical dimension of occlusion. And basically that means that her bite is collapsed. You can see that her 2 front teeth overlap her lower teeth almost, I would say 80 or 90%. She does not, her teeth aren't holding themselves up in the same height dimension in terms of her face that they used to probably 20 years ago. And so she has a bit of an excessive overbite in that area. I also see that her occlusal planes are uneven. And what I mean by that is when you look at the photo on the very bottom, I don't know if you can see my mouse. When you look at the photo on the very bottom, as I trace this around, it kind of dips down and then up and then down and then up and then down. In residency, we used to call this roller coaster occlusion, which is not a technical dental term, but is pretty descriptive. Most of this problem is occurring in the mandible. When I trace her upper arch, it's there, but it's not as severe. We like to see sort of a slight dip, a slight curve, which she doesn't really have anymore, but it's certainly not anything like the lower arch. So the biggest eyesore in terms of previous dental restorations, of course, is this whack bridge on the lower right that somebody did many, many years ago. And you can see it curves really severely. Like nobody even really tried to make a bite that was somewhat correct over here. And it's in what we call crossbite. So in a healthy occlusion, the top teeth, let's see, does she do it on the, yep, she does it on the left side. So this is somewhat more of a normal bite on the left side. Her upper teeth are overlapping her lower teeth. On the right side, her lower teeth overlap her upper teeth. That's called a crossbite, and it's actually pretty unstable for your teeth to be in. What else? But we noticed that this is really the only crown and bridge work that she has in her mouth. Otherwise, she hasn't had a tremendous amount of dentistry done in her life. So the problems that she's having are not really due to decay or neglect. It's due to her parafunctional habit, which is the grinding, and it was exacerbated by this bridge down here that's pretty old. And just in terms of a cosmetic thing, her midlines are off. Her whole lower dentition seems to be displaced to the right side, almost by a full tooth, actually. Like you can see here, this is her canine, and she's got incisor. So this is really where her lower midline is, which is like halfway in the middle of her right upper incisor instead of over here where her upper midline is. So these are all things that I see, and I don't see half of this when I just see the chair. I see this by taking photos, by taking really good quality photos that I can, look at home and analyze, because there's so much that you see in a picture that you don't necessarily see when the patient is sitting in front of you and the lighting isn't, ideal, or they're talking or they're moving their jaw in a funny way. So this is sort of like a method that I learned in residency of how to diagnose and how to how to diagnose the problem and then come up with options to solve it. So this is her panoramic X-ray. I didn't include any individual X-rays because they were pretty uneventful in terms of decay. One thing that I put an arrow next to is a little infection around that tooth, number 28. So that tooth, which was under the bridge, I had a root canal done to treat that infection. And in terms of her TMJ problems, her jaw pain was localized to the condyle, and the condyle basically is this, which is like the ball joint itself of the mandible. And her headaches were in the temporalis region, which is the side of your head by your temples. And she had pain when I palpated her masseter muscle. Your masseter muscle is the big muscle that attaches to the bottom of your jaw that controls your chewing force. So none of this is that surprising, that this is where pain would be in somebody who is a very intense grinder. So a big component of my exam for this patient, in order to evaluate her TMJ, was something called intraauricular palpation. And essentially what you do is you stand behind the patient and you put your pinky in their ears with the pad of your finger facing forward. So if you picture your anatomy, which you haven't really learned yet, but you can see in this picture. So this is the condyle here that we talked about, the ball joint of the TMJ, and the ear is right behind it. So if you're putting your finger right here and the patient opens and closes and the condyle slides around, what you feel on the pad of your pinky finger is the backside of the condyle. So when you put your pinky in the patient's ear, you then have the patient open and close. And what you should feel in a healthy patient is a nice smooth movement as the condyle rolls forward and back. But with this patient, when she closes, I felt like somebody was squeezing the living daylights out of my pinky. Really, really intense pressure. And essentially what that tells me is that this condyle is not in the right place anymore. It's shoved back towards her ear. It's too far backwards, or in other words, her jaw's a little retruded. And so what's happened is, with all the years of wearing her teeth and losing that vertical height, her mandible has actually become displaced posteriorly a little bit. And when she's in this position, here's your temporalis muscle, and your masseter muscle is here. And so these muscles are kind of in hyperdrive now. They're constantly contracting, and she's in pain. So now we've kind of related her habit of grinding, the dental condition that resulted from it, and her symptoms. And now that we know what's going on, we can make a plan. So the plan here was to, without getting too technical with a lot of explanations, I'll kind of boil it down to this, which is that in order to bring her jaw back forward a little bit and put the joint back in its proper place, we need to make some of the teeth taller. We need to restore the height of the teeth that she lost. And we can do this with crowns. We're going to do the crowns pretty much on the lower teeth for reasons that I don't need to get into extensively here. And then for cosmetics, because she kind of ground the crap out of some of her upper teeth as well, those teeth will get crowns. And we're not going to do veneers on her because I don't trust her occlusion. I don't trust her to stop being a grinder. And although on the lower incisors, if you look at these teeth, they're very, very small. So if I reduce these teeth for full crowns, they're going to be very, very, very tiny. So these on the bottom were sort of like 3/4 crowns. They wrap around a little bit, but we save some of the tooth on the backside. Okay, so here's the plan. We are going to do some crowns on her, and hopefully solving the functional problem will guide the treatment plan. And usually when you correct the occlusion, it ends up being attractive. AKA a corrected occlusion will also be an aesthetic smile. So we're going to fix her, we're going to address her chief complaint of wanting a more beautiful smile by also fixing her bite. Because typically in nature, things that work well also look good. So the first step in all of this was, there are a lot of ways to do this. A lot of different doctors will have different methods, and that's the beauty of dentistry. But the way I did it here was to first test out a new jaw position and a future tooth height with a removable appliance. So I made her this clear acrylic bite appliance. I made it by, I took some measurements beforehand. It's a little complicated, but ultimately this is what it looked like. And her instructions were to wear it all the time except when you eat. And then in 2 to 4 weeks, we will see how you feel. And in 2 to 4 weeks, I asked her how she felt, and she said, amazing. I love this thing. I want to wear it all the time, and I have no more headaches. So that's, a good indicator that we're headed in the right direction. So then we're ready to actually touch the teeth. So we started on the bottom. You can see this clear stent is based off of the mock-up of how tall the final teeth need to be, which was pretty tall, actually. I think we ended up reducing them a little bit for the finals. But it's also used as a way for me to know if I reduced enough of the tooth that I can fit porcelain on top of it without making the final tooth look too bulky. So then she leaves with temporaries on the bottom. She literally was with me for the entire day. We prepped the whole arch in one day. She was like half on the phone, dialing into conference calls with her headphones, and she was a really, really awesome patient. Then when the lowers were done, we moved to the upper arch, and these are her temporaries. And I'll just make a comment about temps, which is that the best thing about temps is that they are temporary, and they're like a trial run for your finals. So these temps, we get to look at them and we get to make changes before the final crowns are made. So these were still a little bit bulky, in my opinion, a little bit long. I don't love the contour of the canines. And so these are all things, I print this out, I blow it up on a huge piece of paper, and I take a pen and I mark it up for the laboratory. So as they're making me my final crowns, I can tell them, shorten this, lengthen this, round out this corner, all of these things. And it's also time for the patient to test out the bite and also to test out their speech. You want to make sure that they're not lisping and things like that. So here she is at the end, and she obviously has very much improved dental aesthetics. She has also, if you look at the picture of her face, she has much better facial structure and proportions. She has a more appropriately toothy smile. You can hardly even see her teeth originally. She looks younger. Her skin looks better. These folds, these are called the nasolabial folds that run from your nostril to the corner of your mouth. These are much less pronounced in her final, which means that all of her facial muscles are less constricted. And we've successfully addressed her chief complaint. We've taken her out of pain. We've given her the smile she always wanted. And this is one of my absolutely most rewarding cases that I've done. She was a really wonderful patient, great results. And it really showed me, what I'm capable of with restorative dentistry, which was awesome. I know we're almost out of time, but this is not as in-depth here. I'll just kind of give you a little bit of a taste of what's possible in terms of implants. So this is a good example of a lot of the cases that I did in residency. We did plenty of ones and twos, as we like to say, a single tooth that's missing, two teeth that are missing. But the most fun for me is doing a full arch. So this gentleman came in, this photo up here on the top left is him at the beginning. And actually, so is this, it's just retracted. So when he smiles, it doesn't look so bad. He was, how old was he? Maybe like upper 60s, low 70s. He had this prosthesis on the top that he started with, we call a roundhouse. Essentially, he had about 6 upper teeth remaining, and decades ago, a dentist made him a one-piece, like huge span bridge that gets stabilized across the arch. So for whatever reason, many decades ago, he lost many of his teeth, and back before implants were extremely predictable, this was a really popular treatment. There are so many people like 60, 70, 80 years old now who have roundhouses in their mouth. And they last for a long time, as long as they're cared for. But usually, ultimately, they fail. And so that's what was happening with him. The remaining teeth underneath were failing. And so at that point, you're at the end of the road. But the teeth, they have to come out. And if the patient is not content wearing a removable denture, then you have to talk about implants. So when you lose all of your teeth, you don't replace. It doesn't go one implant, one tooth. You don't need to place an implant for every single tooth that you're replacing. Similar to the way, he was able to have this bridge replacing all of his teeth, but he didn't have all of them underneath. So usually what we would do is place for the upper jaw a minimum of 6 implants for a single prosthesis to go on top of them. And the number and the spacing all depends on what the patient has for you to work with their bone. So for him, this patient was begging me to give him his implant and give him a temporary that screws into the implants the same day I took out his teeth. He was just distraught at the idea of ever having to be in a denture, even if it was only for like a healing period of 3 months or so. So I said, okay, we'll take a CT scan before we do anything and just see what you've got here. And so these shots over here are part of the planning that I did in the CT scanning software to see if, we can get implants in places that we like. And so he actually had some pretty decent bone. And even you can sort of see here, this tooth, this root here, there's obviously a tooth there, but there's all this other bone up higher that I can engage. So I don't really care if I take this tooth out and there's a little hole here. There's all this awesome bone up top. So if I place a longer implant, then I can get an implant in really sturdily, even though I also took that same tooth out that day. It takes a bit more skill, and it takes a lot more care and attention, but it can be done safely, predictably, and when you can, it's a really great service to the patient, because that means that you're shortening their timeline by many months. They don't have to take out the tooth, wait to heal, then come back for the implant, wait to heal, and then come back for their final crown or prosthesis, whatever it is. So the other interesting thing that I'll point out about this is that these two implants on the very end are angled to the back, and that's intentional because this patient, again, didn't really want to wait, and so we're intentionally skirting the sinus here. This structure that I'm running my mouse along is what's called the floor of the sinus. This is the inside of the sinus itself, which is filled with nothing. It's an air-filled cavity, or in his case, he has a little mucus here. That's why it's a little hazy gray instead of just all black, but not a huge deal. But this is, if I put an implant straight up, it's just gonna poke up into the sinus, and then that means that it's not surrounded by bone, keeping it stable, which is what I really want. So if I angle it like this, then I can use a special part to re-angle it in the way that I need. And that's something that's just really phenomenal that the implant companies have come up with, all of these really creative ways to get around biology. And that's probably the most rewarding part about all of these things that I feel is that we really are able to manipulate biology and give people really natural, lifelike looking restorations because of it. So sorry if you're squeamish, but if you're squeamish, you probably shouldn't be a dentist. But this is some photos of his surgery. So you can see in the top right, his teeth have been taken out and the gums have been reflected back. So you can see some of those extraction sockets. And in the middle picture here, this is essentially a sort of a guide. It's not a full surgical guide because I was anticipating a little variability here. So I didn't do it with a true computer guide. I did it essentially freehand, but not so freehand because I still want to make sure that I'm putting implants in locations where I want future teeth to be. If I put an implant in and it's right here in the middle between number 8 and 9, that's not helpful. That's not going to look good ultimately because there's going to be a screw access hole right here where I don't want it to be. I want my implants to be directly behind where the future teeth go. So this is a guide that was made off of a tooth design that we worked up before his surgery. So here are the implants put in, and these silver cylinders are called temporary abutments, and that's what we use to attach his temporary to. So they stick up through the gum so that we can attach something on top of them. So then down here on the bottom left, this is his temporary, and he leaves looking literally like this on day 1, which is pretty amazing considering this is what it looks like underneath. And the reason why we're able to do this, why we're able to give him a temporary on the implants on the same day, is because number 1, all the implants went in really solid. They were really strong. And number 2, because this prosthesis connects all 6 of them It's called cross arch support. They're all holding each other up. So they can't move. Even if he's chewing, they're all splinted together. It's like putting a cast on your leg, like an old-timey kind of cast, not like a boot. So nothing can move. Everything is fixed together. So as the bone heals around the implants, they're all stabilized by this temporary, which is pretty awesome. And this is his panoramic X-ray when he left, showing everything, nicely in place. And then he just has to wait a few months, and we turn this temporary into the final. But this is, this is like the real deal. This is what gets me totally pumped up and excited and feeling like I changed this person's life by being able to do this for them and do it well. And so, I love doing bread and butter dentistry. I love doing single crown. I love doing single onlay. I think there's so much beauty in that as well. But I hope that in my career I can incorporate at least some cases like this once in a while. Also because I enjoy the challenge, and I like to continue to learn. So those are my 2 cases, and that's a wrap. So thank you so much, and I'm happy to answer any questions you have.
Thank you so much, Dr. Emily. That was really amazing, especially the in-depth cases. I myself was really intrigued. I actually have a question. How long did the last case take? So you said it took a day, but how many, hours did it take for you to complete that?
Yeah, truly 9 to 5.
Wow.
So there are ways to shorten that timeline. I did this case sort of in a more old school kind of way. So it took longer, but it was also part of the learning experience for me at the time. To cut down time, number 1 is to not place the implants freehand, is to use a true surgical guide. A true surgical guide looks sort of like this, but it also covers part of the palate, and then you actually end up going in from the side and putting a couple of pins to stabilize it in place. And then there are special rings that you drill through to put your implants in. So everything is pre-measured out. The exact location and depth and angulation and everything of your implants has been established already. So literally it's mindless. All you have to do is go zoop, 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 and it's done. And it's amazing. And so that is much faster than when you have to do it freehand and you're looking and you're checking your angles and you're feeling around and making sure that it's good. I did it freehand because since we were taking so many teeth out that day, I just didn't really trust that the guide that his bone would look the way I thought it would anyway. And the other way to shorten it is by having a laboratory make you a temporary, as opposed to I made this temporary by taking a denture and I personally attached it to all of these temporary abutments myself. So there are definitely ways that you can cut down on time, but it's good to learn both.
Right. So did you anticipate it to take that long, or did you have to readjust your schedule?
Yeah, I did. I blacked out the whole day.
Wow. That's crazy. Okay, so we can move on to the YouTube Live and Instagram. So someone asked, have you worked in corporate dentistry? If you have, do you prefer private practice or corporate?
I have not worked in a big corporate, a corporate office in New York. Dental 365 is a really big one. I know out west there's a lot of Aspen and Heartland. So I haven't worked for one of those, but I have worked for a couple offices that are local chains.
Yeah.
They have, 5 or 6 locations in the area sort of thing. And I can't really speak to what makes it better or worse necessarily. One thing that's really nice is that when you work for corporate, you get to go into work and you do your job and you come home and like you don't have to deal with any of the management. You don't have to worry about the staff and like, oh, you know, my assistant's leaving, we got to hire a new one. And you get benefits, and there's a lot of security in the way that you're paid and the way the money is collected. You know, a lot of the pitfalls of working in a private office is that you are at the whim of whoever your practice owner hired to do all of the things that make your job easier and all the things that make you able to get paid. So if your practice owner hired people who are not good at those things, then that really impacts your life and your bank account. In the chain office that I worked in, I didn't end up staying there, but also he took a lot of Medicaid, and in New York especially, Medicaid reimbursement can be really, really low. And so it's not that I don't enjoy seeing all different types of patients. You know, I loved in school and in the hospital seeing, you know, patients who have lower dental IQs, who don't know as much about what's going on. Like, that is fulfilling in its own way. It's more that because you get reimbursed less, you have to see more volume. And so I can't handle being double or triple booked, and that's what was happening there. But that does not happen at every single corporate office. I know that is for sure not, you know, a blanket statement. I have a good friend from dental school who's a pediatric dentist who works for Dental 365, and she loves it. So it's really, you know, if you have the opportunity to try it, then I'm a big proponent of just trying things. Like, you can work for a few days. For me, I think it doesn't even take more than like 2 weeks to work in a place to really know what's going on and whether or not it's a fit. So you don't necessarily have to sign a contract on day one. Just give it a shot, and then you can see if you want to sign.
Right. So would you say the average salary for corporate and private are about the same, or is there one that's like?
I think that the ceiling is higher in private. I think that you have the potential to earn a lot more in private, but whether or not that happens and how soon it happens is a little more uncertain. When you go into corporate, you are making a really nice salary right off the bat. But if you stay there for 2 or 3 years, you probably will end up earning less than a person who has been in private practice for 2 or 3 years and has grown that practice.
Right.
So it's kind of like a tough call to make, and you can bounce back and forth. Because like I said, you can start in a private office and think the sky's the limit, and then turns out the sky is really far away.
Right. Thank you. Okay, so I think we have time for one more question, and then we can end. So you mentioned mission trips, and then how pre-dental students should be really careful. So would you recommend pre-dental students to even go on mission trips? And if they do, what do you think the best thing, like what should they focus on and learn during that time?
If you are the type of person who enjoys doing mission trips, then go. Definitely, because there are always tasks that need to be done. You can assist also, and that gives you a lot of like hands-on experience. And you can, you know, talk to the patients, you can comfort them, you can suction, you can retract, you can learn a lot by working chairside with whether it's a dentist or a dental student that you're with. And also you can, like, I feel like at a lot of the ones I was at, like, there were people who were like drawing blood or like, you know, counting pills to put into like prescription bottles for people. Like, there's so many different, or they were like runners, like moving them around from place to place. So they're not the most glamorous jobs ever. You know, it's not the same as like going and being the doctor, but it's rewarding in its own way. And it's, you know, of course it's nice to be in a new place and experience something different. So if that's your thing, then do it.
Gotcha. Thank you so much for the presentation and then the question and answer session. We really, really appreciate it. And yes, if you have any questions, follow Dr. Emily on her Instagram, and I'm sure you can email her as well. So that's it for today. Thank you again for joining us, and we'll see you guys soon. Bye.
Thanks for having me. Reach out with any questions or comments, and maybe I'll speak to you guys soon.